pivot to gastric cancer. And since we're on the HER2 topic, there was several important studies presented at ASCO targeting HER2, both in locally advanced but also metastatic setting. Dan, I know I think about this a lot. Why do you think RTOG-1010 failed?
So yeah, 1010 RTOG study. It took a long time to accrue to that study. I think of like 10-ish years or something like this. And so I think that
by the number of the protocol, 1010, it started in 2010.
Yeah. Now it's 2020, 1010, right?
Yeah, exactly.
So we can add here too. So the problem, I think, there was multifactorial, one of which is just an inherent issue with doing perioperative studies in this disease. It's difficult to accrue. And now you're limiting it to 10 to 15% of the patients who have HER2 amplification. So inevitably, it's going to be difficult to accrue to such a study. And I think, no doubt, that is why sort of the target hazard ratio was quite, I would say, potentially unrealistic, with a hazard ratio of 0.6 for DFS. Like even in breast cancer, where trastuzumab was used adjuvantly, the hazard ratio for DFS in their positive study was 0.77 or something like this, in a disease where it works, and it works better than here. So to think that we would all of a sudden have a hazard ratio of 0.6, I think was a little bit unrealistic. But again, I think that was just a numbers thing. And ultimately, this was a 200-patient study, which is, I think, a small phase 3 and more like a phase 2-ish type of study.
Yeah, 90.
So you point there is that
16% of the patients in the experimental arm actually never went on to surgery.
Yeah.
So are you sort of heartbroken and over the whole HER2 targeted thing and then your adjuvant setting, or what do you think if you were to design a trial now? Should we try pertuzumab? Petrarca path CR rate was relatively high, or should we just move on?
I tend to think that there, like Dan was alluding to, that this was a complicated study and underpowered perhaps for what they were trying to achieve, and perhaps overtly complex in some ways. I don't know if this necessarily means that adjuvant or perioperative trastuzumab should be abandoned. I mean, like you said, the Petrarca study, I thought that was compelling data. Also, randomized phase 2, so not necessarily practice changing just yet. I mean, ultimately, I think for HER2 studies in the adjuvant setting, asking this question a little simpler might be better off because of the challenges of enrolling this patient population, and also recognizing that trastuzumab is going to be used a lot in the first line and in second line, and there's or not just trastuzumab, but first line, and also other anti-HER2 agents they'll be exposed to over the course of their life. So it's going to require some degree of changing the study designs, I think, from the ones that we've been using to date.
Jaffer, thoughts?
Just a brief point, that DFS was actually longer by about 6 months, but it was not statistically significant. So it was like almost 20 months versus 14 months for the control. So I think one problem, as Ziv mentioned, is underpowered study.
Yeah.
So the other thing to consider, I don't think we need to pursue this group of patients right now, because as everybody said, it takes forever to accrue. But I think a molecule like ZW25 or even DS8201A could have been even more effective with a reduced dose.
Dan?
I need to say one other thing in terms of comparing those two studies, Petrarca and RTOG-1010. The control arm of RT-1010 was like 14 months, as Jaffer just mentioned, for DFS. And the control arm for the Petrarca study was like 26 months. So that's like a year difference. And so one of the notions is that maybe HER2 positive disease has a worse prognosis compared to, say, what you'd expect from the cross DFS from the cross study was 30 months, and the FLOT4 study was 30 months. But as you can see, the FLOT4 and the FLOT arm control arm of Petrarca was very close to that, 26 versus 30, whereas the RT arm was substantially lower. So what happened there, and why is that? And it's because it's not clear that it's a poor prognostic factor, since the Petrarca arms are very similar. And so there is one suggestion or possibility in that there's some negative interaction with RT and HER2 positive disease. And there was evidence of this even from the McDonald study from 20 years ago, where in the patients who got no adjuvant therapy did better if they were HER2 positive than if they got chemo RT adjuvantly. And now we see this another update 20 years later, where the chemo with FLOT arm does pretty well, 26 months without anti-HER2 therapy, yet the chemo RT arm without anti-HER2 therapy has 14 months. So, you know, this is something that is another possibility that I think has to be discussed.
Yeah, it's interesting. It's an interesting idea. I agree that the next generation of studies need to select patients in a more sort of sophisticated way. And similar to our MSI study, we're just opened a study in resected HER2 positive esophageal or gastric cancer. After completion of standard therapy, we select patients by ctDNA positivity and then randomize them to receive trastuzumab or trastuzumab plus pembrolizumab. It's a small study with a primary endpoint of ctDNA clearance. It's a challenge to use, however, HER2 as amplification in the circulating tumor DNA as an entry criteria for, you know, to your earlier point about colon cancer selection, because amplifications are not as straightforward to detect as mutations. And many of our patients may not have high level enough amplification to actually shed it into the liquid biopsy.
Especially post-op, when there's no, you've already debulked all of their tumor.
Yeah, so we're actually using a tumor matched approach, where if at least one tumor mutation is matched, and the mutations are easier and more straightforward to pick up than amplification, less operator dependent, then they meet criteria for study entry. So, you know, while we're on the HER2 topic, we can very briefly maybe discuss Gastric 01, the Destiny study. Again, very exciting to see a gastric cancer study in New England Journal of Medicine. We don't often see that, and biomarker selected as well. Zev, maybe you can take this point. Do you think there's enough data now based on Destiny Gastric 01 to consider this TDXD approach in third-line setting in the United States or European patients? If you have a patient that comes in to see you.
I mean, I think it's a good question. I mean, obviously, I think that study is compelling. The way it was designed was clever in such a way that it allowed patients in Asia to only be randomized to either single agents, not ramucirumab. They had already progressed on that, irinotecan or paclitaxel. I think before that happens, we're going to want to see the ongoing data from this country, or Western world, I should say. I think we're going to want to see that data, the single arm study, at least single arm, that is ongoing now in the United States and Western Europe, to at least see if we can approach some of the PFS and response rate data that's been reported in the Destiny trial. I think the Destiny trial had a couple interesting things about it. One of them, obviously, is that they did not biopsy patients from the enrollment. They relied on HER2 archived tissue, and yet ended up with a favorable result compared to chemotherapy. In the study being done now in this country and in the United States and in Europe, there is a requirement to do a fresh tissue biopsy and confirm HER2 status. So if anything, we should be technically having a more scrutinized and absolutely HER2 positive patient population in our sample size. So I think we'd want to see some at least response rate or similar PFS data, recognizing that it may not be as good as the Asians in our study before we would use this drug, or in my opinion, until it gets FDA approval. That being said, the FDA these days is a little bit unpredictable, so we don't quite know what will happen.
I like it. Jaffer, so if you have a third-line patient coming in, and let's say you somehow magically have access to TDXD, would you give them irinotecan, a HER2 positive patient, would you give them irinotecan in third line in the US as opposed to giving them TDXT? Well, what are your thoughts about it? Let's say patient progressed on Taxol RAM.
We are actually, you know, we have several molecules like you might have that are targeting HER2, and some of them are.
You can't do that. You can't say you're going to put them on a trial. Let's say there's no trial available.
Oh.
You have to make a decision.
And I have this drug available. Yeah, I would use this drug. I'll probably use a lower dose, but I'll definitely. So this drug, you know, as Zeev said, this is very active drug. There's no question about it. In third line, you're getting 40% response rate. That doesn't happen with any other treatment that we know. Maybe, you know, ZW25 comes close. So that's one really important thing. Duration of response also suggests some like immune activation. And I don't think they have really studied that, but it will be interesting to do that. But I think, you know, the concern that we mentioned before, that if you look at the toxicity table, in every important category, this drug has more events than chemotherapy. So here we have a targeted payload, and then on the other side, you have systemic therapy, and yet this drug, and I think it's a function of the dose.
Dan, what do you think?
A few quick thoughts. I mean, many of my comments are very similar to the colon cancer study in the sense that in the late line setting, in the third line, I think this is a very welcome, you know, addition. And I think I would be a little surprised if the FDA approves it based on what's available now in the US. You know, there's no patients essentially being treated yet with gastric cancer. There's a phase 2 study in second line ongoing now. I would really echo Zev's point that we need to see what the performance of this drug is in Western population, which is more proximal disease, G-junction, esophageal cancer, compared to their majority distal gastric cancer, different cancers, different biology, different heterogeneity. Zev mentioned that they didn't have to check their sample at the time of enrollment to confirm HER2 therapy, but that doesn't mean they didn't. And didn't, you know, so we don't know that information, and we have to be a little careful how many patients were pre-selected before they got into that study from many of these academic centers, because it's very well known to all of us that we want to try and keep people that are HER2 positive into these studies at this time in this common era. So, you know, just because they didn't have to, doesn't mean some weren't. That's one thing to be careful of, that's all.
Well, I mean, it's a randomized study, and to say that, I disagree with you. I think to subject our patients in third line setting to nivolumab or pembrolizumab, let's say, for PD-L1, you know, CPS1 population, you saw the data presented, the real world examples, you know, the responses is, you know, in single digits, or, you know, to punish them with a cytotoxic chemotherapy when the responses and survival is, you know, responses and survival time measured in months as to put, but, you know, I think to say realistically that there's such a disparity between Asia versus the West that we're going to wait another 2 years. I'm not suggesting let's do it in first line or second line, but the truth is in third line, you really don't have anything to offer to your patients. That's
why I was saying it. So for those who are wanting to move it early now, just because.
Right. So, but in third line, you know, if the FDA approves, and they should approve it, I would not be surprised.
Well, the FDA might have trouble proving it for other reasons, right? It's a randomized phase 2 study, and so you know, it's a very important study because the first time, obviously, here we have an anti-HER2 agent have activity beyond trastuzumab. So that's a hallmark moment, and no other HER2 study has shown that so far. It'll be very interesting to see what the FDA does. I mean, obviously, the study is enrolling in this country now, so they may be waiting for some of that data to emerge. Who knows?
Great. So speaking of FDA approvals, I know that there's been strong feelings about approval of pembrolizumab for TMB high population. There was a press release and approval just last month. What do you think about that? Zef, do you want to take it? the first step?
I mean, it's a little, I think obviously the FDA right now is sending us all a nice message that they like tumor agnostic approvals, and that's very clear, and that's a very interesting and important point to keep in mind as we continue to do new drug development. These tumor agnostic approvals are here to stay, I think. TMB is very confusing. I would say that there is not still a standard absolute best way to do this. We saw at ASCO, and we could talk about certainly even within the same studies, how different measurements of TMB are used and how they're not absolutely the same. The way the FDA defined it for a TMB or TMB of 10 or more is eligible for the study, keeping in mind that if you look at the study on which the approval was made, it was non-colorectal cancer and basically a very random bunch of cancers, as you know. I think it faced, we're going to be learning a lot more about obviously what the overlap is with, for example, in gastric cancer with CPS, there seems to be a little overlap in other areas. But if I have a patient in the office who has non-colorectal cancer, GI or gastric primary and has a high TMB score, independent of CPS score, I think this is something to consider now, whereas before we weren't checking it. It'll be interesting to see how quickly this gets adopted, and because it's not necessarily standardized just yet.
Right. It certainly highlights the importance of NGS in these diseases, but I agree.
But if you don't have NGS, right, because we have to consider the fact that in the community, in the community practices, the majority of patients aren't getting NGS testing at this point. So are they now to be ordering TMB on every single patient just because we have an FDA approval for second line? I mean, this is a practically difficult question to answer, actually.
Yeah. Jaffer, thoughts about immunotherapy? And actually what I'd like you to pivot on is the subgroup of Keynote 61 data and the Mayo data suggesting that somehow, third line therapy after pembrolizumab may work better even in pembrolizumab failures. So how does that fit into your thoughts on sequencing of immunotherapy once you administer it?
I think we've seen that phenomenon from very early on, but I don't think the data are all that convincing at the moment. We certainly need more data, and I'm not aware of this phenomenon in other tumor types where where immunotherapy is used up front. So I'm not quite sure. But I wanted to make a comment about Pembro, and you mentioned already that it's not necessarily a very good drug in gastric cancer because most patients don't respond. And so we should start selecting those who have high CPS or high TMB. And we're not doing that. There are 2 randomized trials without survival benefit, and just subgroup analysis was presented at ASCO showing survival benefit after like 80–90% of patients are dead. So we already know that is going to happen because you always get this little tail from checkpoint inhibition. And if you go to the extreme right side of the curve, the difference is going to be statistically positive. That's called Wilcoxon's. But if you compare the whole population, there is no difference. So I think, this is all the discussion we are having, I think is fantastic because you got TMB, you got high CPS score, and you got algorithms now with NGS. You can figure out the neoantigen, whether they're immunogenic or not. So these things are coming our way. And so I think it's exciting that we'll be able to select drugs based on that.
Dan, in your practice, do you see most of the referrals that come to see me from community already have Foundation Medicine or one of the other commercial platforms done? How often is that a barrier, you think? And is NGS typically very available to your patients outside of even, your academic center?
Yeah, I think you asked that years ago. I think clearly it's not happening. But I've noticed, at least in the Chicago area, that over the years, and certainly now with FDA approval of the foundation platform several years ago now even, and Medicare payments and many other commercial companies offering these assays, I'd say the majority of our patients we're seeing as consults now already have it from the local oncologist. And so I don't think that that's going to be a barrier there. And along the points that was mentioned earlier, it was sort of the same question as to when the MSI high pan tumor approval came out. It was like, so now do we have to check all of our upper GI cancers for MSI high? And the answer should be yeah, because
Yes.
for MSI high, it should be a strong yes. I'm a little bit not convinced yet about TMB, and I'd like to see more data after excluding MSI high, which are all TMB high, and the high CPS. And is there still a residual benefit of those other TMB highs outside of that? And I just want to see a little bit more information before I jump at that one.
Great. And what do you think? Do you think Pembro makes Ram Taxol work magically better?
I don't. I'd like to see some more randomized data. I think the data are hypothesis generating. It's sort of a retrospective analysis, but it's subject to a lot of bias. And so, I mean, it's a possibility. We thought the same thing in Keynote 62 in the cohort 3 first line arm, where patients who were getting Pembro monotherapy all of a sudden were having like miraculous response rates later. But in the end, we have randomized data now with like Pembro versus chemo in first line, and we don't see that miraculous, second line response to many of those patients who got Pac-Ram, for example. And so, I think we need to see more data before I jump at that one also.
Jaffer, do you use ramucirumab with any other regimens, such as FOLFIRI? And what are your thoughts about the AIO data that was presented?
I don't, but I think it's an important study because some people are using taxane up front, which they shouldn't. Even the FLOT authors have recently published saying, don't do that in metastatic setting. So, but I think it's an important one because, there are a lot of times you have first line patient coming off first line, have significant neuropathy, and then you can't use paclitaxel. So I think this study probably will become important. And I think I agree with their conclusion to do a phase 3 study. I think it's going on in Japan. I don't know the comparator though.
So in your mind, Zev, is this practice changing?
I think, look, FOLFIRI, ramucirumab, we already know irinotecan-based regimens. Some people do use them in gastric cancer a lot sooner than we tend to do in the United States. There's already good safety data with this regimen in many cancers, colorectal cancer and in gastric. So I think it's certainly a reasonable option for someone who's been on platinum-based therapy and a taxane to use this regimen. I think it's an active regimen. I agree with Jaffer. It's going to be a challenge to see what their control arm is going to be as they indicate the randomized phase 3 is going on, whether it's in Germany or somewhere else. I don't know. But exactly how their control arm is going to look will be interesting.
Dan, do you think this is a worthy phase 3 to run, or is this something that's, do we need to answer that question in a randomized phase 3? Seems like we should be answering more innovative questions.
I completely agree. I think you had me at hello. The few points that I wanted to say is that in my practice, I've been doing FOLFIRI RAM since essentially RAM was approved 5 years ago. And in fact, Zev here on the call and also Sam Klempner, together we put our data together and we already did a retrospective analysis. And it should be known this is added to the NCCN guidelines as an option for second line in January. So this is an option. We have now randomized phase 2 data showing it's at least equivalent, if not even better, trending to better with PFS and things like that. I agree with you. I don't think it's necessary to waste resources on this in the second line. I think it's already should be something that should be an option for patients. It's common to have neuropathy after first line platinum. It's common to have quick progression after carbotaxol RT or FLOT perioperatively. And what are you going to do? It just makes a lot of sense to use FOLFIRI RAM in that setting. in all those settings. So for me, it's just a no-brainer, and it's already part of my practice.